Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.
For everybody with an interest in NASH or, more broadly, fatty liver disease, surf's up, because episode 33 of Surfing the NASH Tsunami starts now. For those who've listened to the myriad technical foibles of the past couple of weeks, this week we are using a new broadcasting system called Riverside FM, which will be fantastic once we've worked the bugs out. At any rate, this should be a lot better. It should be cleaner, and it should enable us to get you better copies faster, which is really exciting. We're doing it now so that we have it in place for AASLD in 2 weeks. So the last 2 weeks, as befit all the technical problems we had, listenership started a little slower and then picked up, which is great. And this week, we are in the second week of prepping for AASLD. So a couple of AASLD updates and reminders. As I mentioned last week, Jorn Schattenberg and Vlad Bratziu will reprise their day after review with all of us. On November 15th, as we said last week, Dr. Harrison will be helping his wife celebrate her birthday, but we'll be fortunate to have Naeem Al-Khoury with us. Manal Abdelmalek, who you will all meet in just a minute, will be joining us on the 14th, and Dr. Mary Ranello, who you met previously, will be joining us on the 16th. And Manal's here today. Do us a favor. Boy, we're really in mood today. Do us a favor. Just take a couple of minutes and tell everybody a little bit about yourself, what you do for work, what you do for fun. And then in the end, I'm going to ask you to tell us one thing we wouldn't know about you if you didn't tell it to us.
So I am Manal Abdelmalek. I live in Durham, North Carolina. I am a hepatologist. I love the field of NAFLD and NASH and have been in it for 25 years. I have 2 children who are triple black belts in Taekwondo and dabble in a little music, although they're still learning. And one thing that you may not know about me is I had the privilege of being a first-year resident at the Mayo Clinic when this whole entity of NAFLD and NASH unfolded, and I had the privilege of reporting the first case of progression to cirrhosis, and my abstract got denied 3 times before it got accepted because nobody believed that this actually happened, and the reviewers kept turning it back, asking me to look for all the alcohol. So here we are 25 years later, and we've come a long way.
So, Stephen, thinking you've been in this field roughly that length of time.
She's older than I am.
Oh, no, I'm not.
He's so polite.
You are such a gentleman.
She's rocking it. If you could only see her and not just listen to her voice.
Yeah, For those of you who didn't notice, not only have we had things falling down, but it's gotten us off to an entirely raucous, but I think wonderful start. Okay, so beyond what's going to go on with AASLD, as I mentioned last week, Jorn will be here next week to discuss his article in Expert Opinion Investigational Drugs, dissecting 10 failed NASH programs. I figure Stephen was only part of 8 of those, but now you're probably only, 5 or 6? So we're going to all get to share those lessons, which I think is a good thing. And that we will be headed into the AASLD episodes themselves. So today is preview number 2. Last week, Donna, who's not with us today because she's moving offices, and Naeem, who's not with us today because he's good enough to pinch hit last week, mentioned some abstracts they thought were of interest. Today, Stephen and Manal and I will try to do 6 of these in the next 50 to 55 minutes with occasional bursts of raucous laughter, so we'll see how it works. I'm optimistic. So let's start with our icebreaker, either personal or professional best of the last week.
I'll go first. I'll go personal. I braved COVID Friday and got on an airplane and went home for a family reunion to see aunts, uncles, mom, dad, brothers, and sisters, and got back last night, and it was a fantastic time. So for me, just to be able to get back to my roots, which is Mississippi, and just kind of get back to the way I was raised, fish and hunt and do some good stuff was a blast. So I'm re-energized. I'm ready to go.
So, Stephen, exactly where in Mississippi were you raised?
In Jackson, the capital.
Okay, good. I used to spend a lot of time working with the pharmacy school at Ole Miss and was once a medical anthropologist there, collected the mud that the folks on the Delta ate to amplify their diets. And he had these pill jars of mud. He would talk about the differences in flavor and essence. And after a while, you thought he was talking about red wine.
Yeah, and then he was talking about mud.
I think you remember he was talking about mud because they all tasted the same. Yeah. Okay. Thanks. That's my recollection.
There's a little known fact about the University of Mississippi is most of us that went through medical school were taught by Guyton's physiology textbook. And Professor Guyton was on staff at Ole Miss for decades. And I was one of the fortunate last few that actually got to be taught by him in person. I think he was like 85 when we were in lecture with him. So Guyton's physiology is still a textbook everybody my age and older would recognize.
Okay. And even some people younger than you, like Manal, who was nodding.
That's right.
Okay, who goes next?
I'll go next. It's quite quick. It's getting with the kids back to school after half term. We're about, as you're probably aware, to go into a national lockdown in the UK. So actually, the only things that we're not closing down are schools, colleges, universities. So to get the kids back to school is a pleasure. So
I thought they were still in diapers.
No, I wish. Actually, I don't wish. They're all stepchildren. So they came to me house trained, which was perfect.
Manal, you're next.
Well, I haven't done too many airline trips unlike Stephen here, but we tend to do the road trips, and I'm looking forward to the road trip back home to St. Louis, which is where I grew up. So as I was leaving, Stephen was coming in for his residency and fellowship. I'm hometown St. Louis, Midwestern girl, so I look forward to going back.
Excellent. I've made a home studio for myself. It's not like Stephen's spiffy studio with the new shiny Summit and Pinnacle signs behind them, but I've made a home studio for myself where I can do this podcast at home in the future. So I promise everybody that in the weeks to come, I will start doing a Stephen and wear funky baseball caps every week. And now that this is on video, occasionally people might even get to see them. You're now looking if you can see where Stephen ducked out of at his shiny Summit and Pinnacle signs. Very, very cool. All right. So the way this week works is pretty simple. Each of us, Stephen, Manal, and me, will take 4 or 5 minutes and discuss an abstract that we find interesting from the upcoming meeting. And then we'll have about 5 minutes of questions, and then we'll go on and we'll rinse, wash, repeat. We'll do 6 of those all told. That should be a pretty good episode. Why don't you pick one of the 2 abstracts that you had selected and take a couple of minutes and let's go through it.
Okay, so I selected abstract, I think it's number 60. John Schonenberg and his colleagues really wrote what I thought was a really fascinating abstract that's going to give us a glimpse, I think, into the future of clinical care. And what this abstract intended to do is really look at machine learning and in its ability to ascertain fast progressors with NAFLD and NASH, and to render assistance in its ability to predict progression to cirrhosis and hepatocellular carcinoma. And what they did is they utilized a retrospective longitudinal electronic health record system, Optum, which looked at health records for patients from all the way from 2007 all the way to 2018. And they assigned an index of prediction. You know, patient had to either have a diagnosis of NAFLD or NASH, or a diagnosis of type 2 diabetes, obesity, hyperlipidemia, hypertension as proxies to NAFLD and NASH. And they modeled 2 indices of progression, a fast progressor, which had a clinically meaningful outcome anywhere between 6 months to 3 years, and a standard progressor, which was anywhere between 6 to 10 years. And ultimately, using this light gradient boosting modeling, which contained 44 features, they were able to demonstrate that artificial intelligence using clinical predictors could render an area under the receiver operating curve of 0.77 and facilitate the recognition of a potential fast progressor. And so some of these clinical variables were beyond what can simply be done with something like a FIB-4 or even a NAFLD fibrosis score, because it looked at not only age, but maybe the rise in alkaline phosphatase, the AST to ALT, the bilirubin, the albumin, lipids, HDL, triglycerides, and would generate a predictive assessment of a rapid progressor or a standard progressor. And so I think this study is fascinating is knowing that we are now in an electronic era of health records. You can envision how a clinician could be sitting and seeing a patient prospectively and have artificial intelligence built into the electronic medical health system such that with follow-up, a potential ascertainment of a fast progressor for a clinically meaningful outcome could be depicted using a 44-point risk model, not only labs, but demographics, the risk of anxiety, and facilitate early recognition and potentially define follow-up. Now, we're not quite at that point yet, But I think this abstract gives us a glimpse as to how mechanical learning, machine learning, artificial intelligence could be integrated into an EMR-based system to define for a clinician more readily and more accurately than they can define it themselves, a fast progressor who's going to develop progression to cirrhosis or hepatocellular carcinoma. So I'm going to love seeing where the future of artificial intelligence will sit as we integrate such technologies into clinical practice.
So, Manal, it's interesting. We talk a fair amount on the podcast from time to time about machine learning and AI, but very rarely in that sense, right? A lot more about doing a better job of reading biopsy. I think, Stephen, that would be the main one, or Louise, that we talk about. This is a whole different game, right?
This is a whole different game because I think it really has the potential not only to model a unique patient's characteristics and fit it into a prediction of rate of progression. And I can envision where if a clinician can identify a fast progressor from somebody whose clinical outcomes are a decade down the line, that can potentially tailor not only how we screen patients, how we survey them, how we monitor them, and it will allow us to get away from the one-size-fits-all model into a more patient-tailored approach to risk stratification and follow-up.
Yeah, I mean, I think this is exciting data. It's early days, but if we can identify who that percentage of people are that rapidly progress to fibrosis, that would be key, because we can implement strategies to try to reverse that much more quickly. In addition to that, knowledge is power, and being able to inform the patient that they are at increased risk of progressing more rapidly, that would be huge, because again, we can alert the patient that while they feel good today, 5-10 years down the road, they may be the one person that, we would be worried about progression to cirrhosis or even liver cancer or something else. And the other thing that's really neat about this is when I'm sitting in clinic, there's a lot going through my head and trying to remember, okay, are they a diabetic, or what's their BMI, what's their AST, what's their AST-ALT ratio, what's their alk phos, their lipids, triglycerides, cholesterol, HbA1c, how many medicines are they on? All that, this AI machine learning takes all that, synthesizes it for you, and processes it so you don't forget variables that could be impactful in the model. If that could be applied across the waterfront, that would be huge.
And what's interesting about this is, while there are variables in this model that are intuitive to hepatologists, a drop in albumin or a rise in bilirubin or a drop in platelet counts, there are other variables that aren't so intuitive, like a patient's anxiety rate. And BMI in and of itself didn't really come out as having any statistically significant difference in this model. So I think it pulls away the onus of cognitively reasoning through multiple different variables to ascertain, while you're sitting in a clinic, is this a patient who's high risk in my practice or potentially somebody who's lower risk? This really is a far more integrative, both physiological, demographic, and potentially risk model. And what's interesting is in the model, and it's counterintuitive, fast progressors were actually associated with a weight loss. And one can see that as patients progress to cirrhosis, they may lose muscle mass. That may not be intuitive for physicians in a general clinical practice setting. And so that pulls the modeling away from the hands and the responsibility of the clinician, and really empowers the electronic health system with artificial intelligence to do the hard work in a patient-tailored fashion for us.
I have two questions for you, Manal. First one is, the area under the ROC curve is about 0.7 something, right?
0.77.
So obviously it's not perfect. How do we work the kinks out of that? How do we optimize its positive predictive value, or do we use it for its negative predictive power? Number one. And number two, how far down the road do you see this being implemented, and if at all, and what are the challenges with implementing something like this across multiple different EMR systems?
Excellent question. And I think the challenges that we're currently met with in the field in general, first of all, this needs to be more broadly validated. We know that there are unique ethnic differences, geographic differences, and it may not actually, while it utilizes clinical predictors, it may not be able to capture some nuances that we know play a role in rapid progressors, such as genetic variables. And until we empower these AI learning, artificial intelligence technologies based on clinical grounds, I suspect we're going to be coupling this with a serum marker that allows us to model, in combination with clinical artificial intelligence systems, more omic type of approaches to risk stratification to push that area under the receiver operator curve to at least 0.9 or higher, such that we can actually apply tailored clinical care and do so accurately.
So, Louise, you have any thoughts? Anything to add?
I only had a couple of thoughts in the context that we have companies who already backread GP systems to try and find the highest risk patients for HIV, for example, by using proxies such as other sexually transmitted disease, herpes, and acyclovir prescriptions. So if this sort of model works, is it the sort of model that could be placed into primary care? Because we've always discussed, and people talk about the screening of NAFLD not being cost effective. But if you put this into a primary care setting to really pick the highest risk and identify those patients, does that then move us to the potential of being a highly cost effective way of finding the highest risk patients?
I see this as an extension of what may already be happening in primary care. The electronic health system, such as Epic right now, is able to potentially be programmed to assist a provider with a FIB-4 score or a NAFLD fibrosis score. There are some insensitivities with regards to these depending on their content of use. So if NAFLD fibrosis score may overpredict the risk of advanced hepatic fibrosis when used broadly in a diabetic cohort of patients. I see this as one step beyond what we have. And the beauty of it is it doesn't have the potential to be static. It could be very dynamic as a patient's condition or comorbidities change. And integrative 14 characteristic model may allow us to further enhance the performance of a typical FIB-4 NAFLD fibrosis score. But time will tell. I think this is in its infancy, but it shows you the power of an EMR-based system with artificial intelligence being integrated into clinical practice for NAFLD and NASH.
All those are excellent points. The only reaction I had that I guess Stephen kind of touched on, and you did too, Manal, is that the quality of EMR data right now, even in 2020, and the proper use of EMRs as compared to physicians hand-forcing what they want to write or what they want to type onto the choices on the screen, is far too prevalent for this model to work, at least at the outset. My bet is it's going to depend on some fairly high data quality, and we're going to have to figure out what it takes to get people to execute.
Well, the nice thing about this model is many of the variables within it are lab-based. Yes, there's some subjectiveness, such as, the presence or absence of anxiety in a patient, but the majority of it is AST, alkaline phosphatase, albumin, bilirubin, creatinine, protein, and so forth. And so there is some further standardization of it than may be reached with just subjective clinical parameters alone.
Okay, thanks. So, Stephen, normally I would turn to you, but one of the two that I've got is so on target with what Manal just presented. This is abstract number 86. It's actually from Mayo Clinic, going back to where you started out, Manal, from Omar T. Ahmed and colleagues. And what they chose to do was they wanted to take a look at the natural history of patients with lean versus overweight versus obese NAFLD in the U.S. population where they get long-term follow-up. So what they did was they took the records of all adults diagnosed with NAFLD in Olmsted County, Minnesota, Mayo Clinic, between 1996 and 2016, and they tracked all subsequent medical events using a linkage system, divided them based on their BMI into three groups, lean, overweight, or obese, and looked at the probability of developing different kinds of events as well as overall mortality using Allen-Johansson method, treating death as competing risk. They wound up with 4,834 cases, 414 of which were lean, 1,189 overweight, and 3,231 obese. The lean NAFLD individuals had more women and fewer metabolic comorbidities. After a median range of 6.4 years, 74, 148, and 347 individuals died from each group. So the lean NAFLD group had a significantly higher risk of all-cause mortality. 95% confidence interval was about 1.5 to 2.5, value was 1.96. However, they had lower incidences of the various events or no significant difference. So what you were looking at was a very different kind of a disease. They were less likely to develop cirrhosis, the lean NAFLD patients. There was no significant differences in the risk of cardiovascular events or malignancy between lean and obese after they adjusted for all the different variables. And in all groups, the leading causes of death were malignancy and CVD. For whatever reason, however, and HCC liver-related deaths represented 2% 1.4% in the lean, 2 in the overweight, and 10 in the obese. Despite the lack of comorbidities, the patients with lean NAFLD were associated with high risk of all-cause mortality. So clearly, if you take a look at the rate of mortalities and the cost of mortalities, lean versus overweight versus obese NAFLD appear as 3 different diseases in terms of what the downstream effects are. I think that's really interesting because it goes back, first of all, to what Manal was just saying, that the highest cost NAFLD is lean NAFLD, because if you're progressing more rapidly, late-stage events are where the costs are. So this becomes a way to take a look and validate the idea that we're likely to see the higher cost patients being the lean patients. Therefore, Louise talks a lot about the cost of disease, the ones we'd like to intervene in most quickly. If you lay that up with what Manal was just talking about, we may be at the beginning of having a way to do that.
Was there any collinearity with diabetes, yes or no, rather than an HbA1c value?
I'm going back into it right now to see if I can get better data on that, but I do not recall that. Okay, remembering that it's an abstract.
I always struggle with the phenotypic characterization of this lean NAFLD. Clearly it exists, but whether there are various phenotypes within this lean NAFLD cohort, whether it be, combination of alcohol use or serendipitous alcohol use or cholesterol ester storage diseases or familial hyperlipidemias, the heterogeneity even within that cohort and the fact that it typically only accounts for 10% of the entire, at least NAFLD population that I see here, makes it a harder cohort to study. And we, I think, need far more information and data on this lean NAFLD population.
Another reason why we don't like the term MAFLD instead of NAFLD.
As Naeem pointed out in a different context last week, I'm baffled by this affection for MAFLD, but that's a whole different thing. Stephen, the answer to your question was all the data that I just reported was after they controlled for age, sex, diabetes, hypertension, and dyslipidemia. So they don't show you here what the relationship was, at least not in the abstract. But when talking about all-cause mortality, they were controlling for those factors, making death a compete.
Couldn't it still be collinearity?
It could be. You'd have to see data that they're not showing here, right? This is, as I say, an abstract. It'll be interesting to see what happens when they present the paper.
Remind me, how do they define lean? Was it BMI less than 25?
Doesn't say.
The abstract, it doesn't say that either.
Yeah, it was funny. This was one of the abstracts I looked at as to whether I was going to present. And I think Manal said it doesn't break down lean NAFLD as to whether it's methotrexate use, whether or not there's drugs that we know cause. So there's not enough information, I thought, in that yet. So it's been an interesting one to hear.
So ironically, Louise, the one I wanted to choose was the one that you did last week.
The other one I looked at was the one Manal's doing as well. Nice to know great minds think alike.
Okay, so Stephen, let's go on to your first.
I chose abstract number 8, which is entitled Efruxifermin, a long-acting FGF21 fusion protein administered for 16 weeks to patients with NASH, substantially reduces liver fat and ALT, and improves liver histology. This was an analysis of a randomized placebo-controlled phase 2A study, affectionately termed the BALANCED trial. So just in a nutshell, I wanted to just take you through the trial, but maybe just a little background on efruxifermin. It's known that this is an FGF21 analog, and it works on 3 different FGF receptors, so FGFR1C, 2, and 3. And by working on all 3 of these, there are different aspects of that pathway that gets modified in a positive way in the setting of NASH. So you're improving free fatty acid flux to the liver. So you're reducing the free fatty acid flux that's occurring. And you're also working on improving beta oxidation of fatty acids and then reducing de novo lipogenesis. So there's a lot of positive things that come out of this type of mechanism of action. To summarize quickly, this was a trial that was 16 weeks in duration. Ultimately, 80 patients roughly were enrolled into the trial. 3 different doses of drug, 28, 50, and 70, given subcutaneously once a week versus placebo. Primary endpoint was absolute change in hepatic fat by MRI-PDFF at week 12. But there were paired liver biopsies that were obtained, and they were obtained in a select group of people. These people had to have achieved a 30% or greater relative reduction of hepatic fat at week 12. 12 to be eligible for a post-treatment liver biopsy. That's really the message that I want to deliver today that'll be further characterized at AASLD. The primary endpoint was met. The mean absolute liver fat reduction was quite robust. It was 12.3 in the 28 milligram, 13.4 in the 50 milligram, and 14.1 in the 70 milligram versus 0% for the placebo. Looking at relative liver fat reduction, we set the bar at 30% and say that's likely to be correlated with change in histopathology. And it ranged from 63% to 72% in a dose-response relationship. Maybe more importantly, when looking at the percentage of patients that achieved the 30% relative reduction in liver fat, it was only 10% for placebo. All three dosing arms, 100% of the patients were able to achieve that. And there was also nice reductions in Pro-C3, ALT, and that sort of thing. Now, moving on to the liver biopsies, I think the important thing to look at are really the three components that we look at with Subpart H approval. That is fibrosis improvement by at least one stage with no worsening of NASH. And the placebo group had 0 patients that achieved that. From a percentage basis, 46% of the 28 milligram group achieved it, 62% of the 50, 36% of the 70. If you lumped all the efruxifermin patients together, it was 48%. Now, there's a caveat here. Again, I want to emphasize that only patients that had a 30% relative drop in liver fat had a liver biopsy. So that meant only 2 placebo patients had a liver biopsy, and 40 of the efruxifermin group did. So only about half of the cohort that had a response ultimately went to liver biopsy. And I think still impressive numbers nonetheless. Maybe more importantly, when we look at fibrosis improvement by at least 2 stages, we saw up to 38% of patients receiving drug had a response, and that was with the 50 milligram dose. None of the placebo patients hit that. We wrote all of the drug groups together. It was 28% achieving a 2-stage improvement versus 0 for placebo. Finally, on NASH resolution with no worsening of fibrosis, here we have 50% of the placebo group hitting it. So one of the 2 patients who had a 30% relative drop in liver fat achieved NASH resolution. And ultimately, when you roll all of the efruxifermin group together, it was 48%. So that's really the main message for this abstract. There were also substantial reductions in serum triglycerides, as well as increases in HDL, with no increase in LDL. And I think that's important to emphasize, that you were seeing nice drops in liver fat, nice drops in liver enzymes, and improvement in histopathology, but it's not at the expense of LDL. So I think that's a positive. It was safe and generally well tolerated. The most common adverse events were transient mild or moderate gastrointestinal events. And maybe another important point to emphasize here is that there was also improvement seen in glycemic control and insulin sensitivity. So if you want to step back and look at a drug that's working in NASH, a couple things we like to see. We want to see drug move liver fat. We would like to see the comorbidities of that patient improve, if that's diabetes, if it's hyperlipidemia, if it's weight loss, that sort of thing. So we're seeing some good peripheral effects of the drug, not just on liver fat and histopathology, but with the improvements in cholesterol, triglycerides, and glycemic control, that all is encouraging. The caveat being, I think here, early phase, early stage data, and looking forward to more detail from AASLD and onwards as to what the plans are for this drug moving forward.
Stephen, is it fair to say that the highest dose was actually not as effective as the 50 milligram? Is there some type of saturation or plateau effect that the FGF21 compounds may not get as high a stepwise dose responsiveness that we've seen with other drugs?
Well, that's one way to look at it. Another way might be that the numbers are very small. So, when we're looking at NASH resolution with no worsening of fibrosis, for instance, in the 70 milligram cohort, we're talking 14 patients total, 6 of whom met NASH resolution. So that's 43%, as opposed to the 50 milligram dose, where there were 13 patients and 7 of them achieved that giving you 54%. So really it's a difference of one patient. So, had we had more robust numbers, it may be there is a dose response relationship. We actually see that a little bit more with the NAS reduction, which I didn't go into, but this is certainly available in the public domain. You can go to the Akero website and their presentation data is there. There's a dose response relationship. If you look at the mean NAS reduction, it's 2.5 for placebo, 2.9 for 28 milligram, 3.1 for 50, and 3.6 for the 70 milligram dose. So I think it's just a little early to say how effective the doses are going to be. I think I would prefer to lump them all together and compare the mechanism versus placebo at this point.
Certainly the improvement in glycemia and insulin resistance is encouraging too.
Yeah, I think when you look across the board, there was some, I don't know if surprises is the right word, but clearly when you look across the board at what's been done in the NASH field relative to FGF21, we really only have the BMS data. And as you know, pegbelfermin has moved on to two relatively large phase 2b paired liver biopsy studies, one in F3 and one in F4. But in the early phase trial that was published in Lancet, I don't believe glycemic control parameters moved in a positive direction. And same thing with weight. And so that was a bit of a surprise, at least for me, to see that HbA1c, HOMA-IR, C-peptide, and adiponectin all kind of moved in the way you wanted it to. And there was even a dose-response relationship with weight loss.
So, Stephen, given that there's a fair amount of pharmacology around the FGF21s and that they're somewhat different in terms of how they're stabilized, is there any compelling logic about what it is about this medicine that might have it react differently than pegbelfermin or others that we might see, either to the better or to the worse? Is there theory around that?
There's certainly theory. All of the FGF21s are created a little bit differently. So it's not surprising that we're seeing some differences in efficacy and different extrahepatic changes with different formulations of the drug. And I think there's some unique features to these. Not all are pegylated like pegbelfermin. There's different amino acid substitutions that allow for decreased degradation of the hormone and prolonged binding to the receptor, the beta-klotho FGF are 1, 2, 3 receptors. So I think it's a little bit conjecture as to what's going on and why it's leading to the changes that we're seeing. But at the end of the day, to me, as a clinician, I never really understood ribavirin, but I know ribavirin made interferon better, and so we just used it. I think if we never understand the nuances, if we're getting improved glycemic control, weight loss, improved dyslipidemia, and histologic improvement, and it's safe and well tolerated, I guess I don't fully need to know how it works.
Just curious, Louise, you have anything you want to add or ask about?
Only, Donna, sprung into my mind when you said you had to have a 30% relative reduction to get a liver biopsy, and it was like, you've won the lotto. Donna just sprung into my mind. You sold it so well, that how to get a liver biopsy. But I just find it amazing that we can turn around 14 years worth of developing fibrosis so quickly in some of these new medications. So that's exciting. May just give us the license to carry on, but it's great.
Well, I would say, this whole notion of how quickly fibrosis can move is a very interesting one. And I guess it's one where there's still some disparate thought. I always thought it took a while for fibrosis to regress. Thus the reason for the Pivens trial being 2 years, and some of these other trials are 18 months in duration. What we saw with NGM and aldafermin doing liver biopsies at 12 weeks, to me, was eye-opening, where with the 3 milligram dose, we were really moving the needle on 2 stages of fibrosis improvement. And, you could argue that was sampling variability, but man, the non-invasive test really were all moving in the same direction very nicely. And I think for me, if anything, it's comforting to know that now there's a different class of medication used for maybe just a little bit longer than that, 16 weeks, but still seeing this magical 2-stage improvement in fibrosis. So I don't think it's just sampling variability. I think legitimately we are doing some positive things metabolically that are really allowing for the ability of the liver to do its job and really clean up and resolve the inflammatory milieu, which once that's done, hepatocytes are allowed to regenerate, and then the scar tissue just gets reabsorbed. To me, I think that has become apparent that can happen very quickly outside the setting of cirrhosis. Still not really sure how much we're going to change cirrhosis at this point, but if you're F3 or less, I'm excited about how quickly we can make that change.
I agree. I think we've learned a lot about fibrosis, and I think I've come to the realization, as others are, that not all fibrosis is created equally, and a fibrous band may not be the same in its ability to remodel and reabsorb with stage 4 well-established cirrhosis as stage 3 or under. But it has been quite compelling how readily earlier stages of fibrosis can resolve with some of these therapies. So unfortunately, I'm discouraged that we really haven't pushed the needle much on cirrhosis. We've seen many failures on that front, and maybe we're not targeting collagen cross-linking or remodeling in the same manner at more advanced stages as in earlier stages.
The cirrhosis is one we've really got to do work on, Manal, and I can't wait for the day that we're sitting here talking about a drug that's really moving the needle in a positive direction on regression of cirrhosis for sure.
I look forward to sharing that day with you, Stephen, because that would be a very exciting day, won't it?
It will, and I'll actually look 20 years younger when that happens.
Now that you've found Stephen's fountain of youth, why don't we go on and talk about your second abstract?
Oh, well, I think this abstract from Naga Chelasani and his group really nicely complements the first abstract I talked about, because this abstract really helps us take a glimpse into the element of potential future of serum-based biomarker assessment. This looks at the ability to quantify what we call cell-free messenger RNA, and we know that messenger RNAs are really intracellular communicators. And certainly in years past, we have not been as successful of teasing, cell-free messenger RNA out in peripheral blood. But in newer next generation sequencing assays, we've had more success in looking at cell-free messenger RNA in peripheral blood. And this abstract really looked at not only a discovery cohort of 176 patients, but a validation cohort of 59 patients plus healthy controls. And of course, the patients with NAFLD-NASH had biopsy-proven disease with NAFLD-NASH. And they looked for the serum messenger RNA, the cell-free RNA. The patients in the cohort, approximately 52% were stage 0 to 1, and 20% were stage 2, and 28% were stage 3 and 4. And they did ordinal regression, and they were able to detect 2,400 genes that were differentially expressed between the NAFLD patients and the control patients. But what was interesting in looking at the cell-free messenger RNA is in the pathways that came out, as we've always kind of known, tended to be more enriched with metabolic pathways and immune pathways. And they detected that more than 50% of patients, 58%, were able to be readily stratified to having F4 fibrosis or higher with at least 90% probability. So that really gets at the fact that we are moving closer to blood-based biomarkers that, if potentially coupled with clinical predictors, can help us more accurately stratify out those patients who have differentially expressed gene regulation for metabolism and immunity that's happening at the liver level that can actually be reflected with some accuracy in peripheral blood. And with that, be able to risk stratify those patients who should be targeted for promising therapies that are currently in clinical trials, and potentially, if more broadly validated and much larger and heterogeneous cohorts, even in clinical practice. So I thought that was pretty cool.
I think it is pretty cool.
I got silence. Nobody else thought it was cool? I thought it was cool.
No. I've got no questions. I'm like, gee, that's neat, and I've got no questions. So I feel virtually tongue-tied. Kind of like being an 8th grade boy.
I think it's terrific data, but I think it really gets after what we talked about with the other abstract that you presented. It has the potential to change the way we practice medicine by helping us to identify patients that we need to focus on. And, this is one of those things where you're excited and tickled pink to hear about it. You want to dive in and learn more. And that's the whole point of what we do, right? You're serving this up on a platter for Dr. Chelasani to knock it out of the park at the liver meeting. And we'll all be able to sit back and learn more from what he has to say. But exciting.
But I think we can see a future where we're coupling artificial intelligence type of clinical predictive models with blood-based serum biomarkers that actually have overlapping relevance to the pathobiology of what's happening in the liver, with corresponding and overlapping gene expression that can be detected in blood.
So Manal, I think that's an excellent point. And we're already seeing that a couple of levels further up the field than liver is right now in kidney, where CKD is a huge issue and dialysis is massively expensive. People have actually applied a little bit earlier in the game than we're talking about here to creating those kinds of algorithms and figuring out what combination of blood markers and other things that you have to create. And they're now starting to build models that can have a significant effect in identifying which patients need to get treated faster for whatever level of kidney disease they had. Knowing that they're doing it there says, yeah, they can do it here. And part of me being tongue-tied was thinking about how to bring kidney into this particular comment, but I think you kind of set the stage for that as well. I couldn't agree with you more. And I think if you look at what's going on in nephrology, we'll see the kind of promise that's going to be extended going forward.
The challenge with these type of analyses is they're still relatively small in sample size. We really need far, far larger type of analyses when looking at peripheral blood-based genetic markers and their diagnostic potential and validity.
I got to abstract number 67, which is a novel first-in-class fatty acid synthase or FASN inhibitor. This one is TVB2640. It demonstrates clinically significant reduction in liver fat by MRI-PDFF and ALT and NASH. It's a phase 2 randomized placebo-controlled trial, affectionately known as Fascinate-1. Rohit Loomba and many of his colleagues around the country participated in this trial. I was fortunate enough to be one of those as well. And I'm intrigued by this class of drug. We first came to recognize that blocking de novo lipogenesis could be beneficial in the setting of fatty liver through the acetyl-CoA carboxylase inhibitor class of drugs. And so here, we're also blocking de novo lipogenesis, but just at a different spot. The one concern people had about acetyl-CoA carboxylase inhibition was the higher you dose the drug, the higher the triglyceride adverse event profile became. And so one of the intriguing things looking at this cohort was not only the efficacy, but what about the adverse event, the safety of the drug? So I think it's going to be an exciting piece of data. And so this was, as noted, a multi-center placebo-controlled trial, and they were randomized to 2 doses of drug, 25 or 50, given orally once daily for 12 weeks. And you also had to have liver fat more than 8% on PDFF to get in, and evidence of liver fibrosis, either by liver biopsy or by MR elastography, which was 2.5 kilopascals or greater. Similar to the efruxifermin data, the primary endpoint here were safety and changes in liver fat by MRI-PDFF. Responders were defined by that magical 30% reduction in liver fat at week 12. So there were 99 patients randomized. Most had type 2 diabetes. The mean baseline PDFF was 16.7. Take-home message, a clear dose-dependent effect on liver fat was demonstrated. And they have a nice graph in the abstract book looking at the percent change by PDFF at week 12. And you can see it actually went up in placebo by 4.5%, down in the low dose at 9.6, and then down to 28.2 in the 50 milligram dose. So a nice dose-response relationship seen with PDFF response. ALT also decreased with the 50 milligram cohort achieving a 20.4% reduction, not an absolute reduction, but percent reduction. There was interestingly, not all people that were enrolled in the trial had an abnormal ALT. So if you just look at those that had an abnormal ALT, there was even a larger decrease there. So, there were changes in biomarkers of fibrosis and inflammation as well. I think, it's an exciting first pass look at this mechanism. As far as safety goes, it was well tolerated. The adverse events were primarily grade 1 and mild with no serious adverse events. Maybe more specifically, there were no significant difference in triglyceride elevations and no evidence of biochemical or hematologic toxicity. So again, early days, but 12 weeks of this drug appear to be having positive impacts on liver fat and no significant changes in lipids. So I think it's good data. Looking forward to seeing the rest of the data being presented, and then really I want to see what happens on liver biopsy by using this mechanism.
I'm struck by how many more drugs are appearing to have meaningful 12 and 16 week impacts or potential than say, what we were thinking about 6, 12, 18 months ago. And commercially, obviously, and medically, that makes a big difference because people can get excited about something they can see quickly in a reasonable proportion of patients. So just for that, when we start talking about these drugs, I wind up being a lot more excited about where the treatment of the disease is heading, and a lot more optimistic than I think I would have been if we'd had this conversation 8 months ago.
Yeah, one thing that's becoming clear is MRI-PDFF, while it measures inert triglyceride, which has nothing to do with the underlying lipotoxicity that we see in these patients, it really turns out to be a relatively good predictor of histopathologic response, and at least to several different mechanisms. We see it with FGF19. We've now seen it with FGF21, at least early days. We've seen it with the thyroid hormone receptor beta class of drug. And so I'm anxious to see if we're going to see it with the FASN inhibitor. The one class we did not see it in was the PPAR delta. So I don't think it's wholly applicable, but boy, if you're able to show that it correlates with histology, as you pointed out, measuring liver fat content early to predict whether a patient is likely to be responsive is quite helpful. And it may even save dollars because the payers would be able to say, look, I don't need to continue my patient on this drug if they're not having a certain threshold of response on MRI. The next step after this, if we really want to talk down the road, is what do we have to do to put a point of care test that correlates with MRI-PDFF in the clinic? If we could get some device that would allow us to measure liver fat at the bedside and correlate that to PDFF, that would be fantastic.
I agree with everything that Stephen's saying, and certainly the reduction in MRI-PDFF appears to be a very good surrogate for the improvement in NASH. I'm a little reluctant to apply one size fits all to all therapeutic targets. Certainly there may be targets that are downstream of the metabolic drivers and will influence necroinflammation or even fibrosis without hitting that MR-PDFF endpoint. It certainly does appear, though, the anti-metabolic drugs, for the most part, not absolutely, when they drop MRI-PDFF will translate into NASH resolution. But I don't think we can apply that hard and fast rule across the entire spectrum of disease. At least I'm not comfortable with that premise at this point.
I agree with you, Manal. Maybe I misspoke or you misinterpreted something, but I totally agree with you. I think just where you're moving liver fat and you're able to correlate that with histopathology, that's pretty exciting. But certainly if you're a pure antifibrotic play, if you're a pancyclophilin inhibitor like Hepion has, measuring liver fat's probably not the way to go. Pro-C3, ELF score, something like that. Same thing with if you're an anti-inflammatory drug, you're targeting SSAO, ASK1 or something along those lines. And by the way, that story is not completely told yet. I mean, there are other drugs in the pipeline hitting ASK1, even though selonsertib was found to not be effective.
We fully agree.
So I absolutely, yeah.
So let me ask you a question.
Yeah.
Apropos of all that, if thinking commercially now, not purely medically, if we find that a class of drugs that can have an effect on PDFF fairly quickly, that tends to tie to changes in fibrosis over time, and we get the kind of bedside device that you just described, Stephen, in practical terms, how much harder will that make pure antifibrotic plays to break through?
Well, I don't necessarily think it makes it that much harder. It's just you've got to develop that biomarker. Let's take a step back and look at a bigger picture. The FDA is now laying out pathways for biomarker development in the setting of NASH. And you see that being utilized through the Litmus Consortium, through the NIMBLE Consortium, and even some of the artificial intelligence guys are looking at that drug development tool pathway for the context of use of their diagnostic. And so I think what is important is data. The agency looks at data. They're data-driven people, not theoretical people. So, it's important for these pharma companies to look at their mechanism of action and try to apply non-invasive testing strategies that could correlate with histopathology to not only substantiate what we're seeing on histopathology, but through the context of use of looking at therapeutic response to treatment, it could really help in identifying the ideal patient to target for the drug, which we haven't talked about, and then also whether or not the patient is responding to drug and to keep them on treatment. So again, whether it's an anti-inflammatory, it's an antifibrotic, it's a metabolic agent, a combination of all those, I think we need to develop non-invasive strategies. And, there's Pro-C3, there's ELF, there's Pro-C3, 3CM, there's Pro-CX. There's a lot of things being developed in the fibrotic space. There's not a lot of stuff out there for anti-inflammatory as a pure play, with the exception of ALT. So, there's more work that needs to be done.
And I agree with Stephen wholeheartedly. It's all going to be about the biomarker, and why it's so easy with MR-PDFF is it's highly reproducible and very, very sensitive to change and easily measurable. And until we develop that element of a good surrogate for NASH or fibrosis with that level of sensitivity, it's going to be a little bit of a challenging, but I don't think impossible. But it's all going to be about the biomarker and its performance across different elements of injury besides steatosis. And that's what makes it so easy to use MR-PDFF as a good surrogate because of its outstanding performance and reproducibility.
Yeah, the coefficient of variance of MR-PDFF is very good. It's 2%, 2 or 3%. So, if all biomarkers could have that, we would be in a good position. We don't see that same with MR elastography or with FibroScan. The blood-based biomarkers, I'm not sure we really know. Manal, do you know? I don't think we know coefficient of variance with a lot of the blood-based stuff yet.
Not broadly, but certainly the area under the curve isn't as good as with MR-PDFF.
Let me act like I'm an MBA with a marketing degree, which in fact is what I am, and to suggest that frequently it's not the best technology that wins, it's the first technology that gets the broadest exposure. So if we want to be careful not to overplay or not to underplay the value of the things that can't be measured using MRI-PDFF, I would think some pretty fast biomarker work is going to need to get done, or else some consistent advocacy of specific patient populations that can't be addressed by PDFF will need to happen. The famous example everybody gives is 40 years old, and it's Betamax and VHS when they first came out with DVRs, and that by far Betamax was superior technology. VHS got so much more momentum and distribution that the best technology didn't win. We don't like to think that science works that way, but in some ways science and technology are not that different. So it's just a cautionary note that we want to be sure that we have people paying enough attention to the pure fibrotic issues so that they not get lost, particularly since a half hour ago we were talking about reversal of cirrhosis, and that feels to me like it's going to have not much to do with PDFF, but a ton to do with pure fibrosis plays. And with that, I try to learn something from Donna every week, and what Donna taught me last week was don't present your second abstract if it's too late in the program time. So I'm not going to share mine. I will tell everybody that it's Icebreaker 03, and I will be talking about it during the conference, whichever day it comes up. You can take a look there. It's a fascinating look. It's a reanalysis of the aldafermin and the NGM 282 data in terms of differences between the F2 and F3 patient populations. I think it's got some fascinating things to say. We're going to let that go for today. With that, why don't we go to our wrap-up question? I'm going to use the same one we used last week. Something we talked about today that makes you really excited about what's likely to come out of this meeting.
I suppose it's the speed of reversal that Stephen and Manal were talking about earlier, that the fibrosis regresses very quickly in some of these trials, which is really exciting for patient populations and for going forward, I suppose. Yes, if we can get something for cirrhosis, that's great, and that will come along, I'm sure. But it's just amazing how far we've come in the last few years, and so it's startling and very encouraging.
Yeah, I'll chime in and just say, for me, this whole notion of artificial intelligence and even the omics, gene expression profiles and what's happening and where we can go with that. We've talked a lot about that over the years. We've done deep dives into omics before, and it really hasn't taken off. I think we're really at that precipice now where we understand a lot more about them and how to use them. And I think there is an opportunity for us to capitalize on that and really bring that forward into the clinic to use it as a guide to help identify at-risk patients.
What I find most exciting about the liver meeting this on Saturday is the data that we're seeing, not only with artificial intelligence, but blood-based biomarkers, is putting front and center personalized medicine in the care of patients with NAFLD and NASH, such that we're going to get to a point where we can tailor the right therapeutic to the right patient and get the most optimal results. And that's where we need to be. And while I find the 12-week data exciting or early data exciting, ultimately it's going to have to translate to an improved clinical outcome, less progression to cirrhosis, less hepatocellular carcinoma. And what I love about Saturday at the liver meeting is we're seeing very robust progress been made on the biomarker and AI front in general.
Look, I don't usually talk half as much about commercial issues or forecasting issues anymore as I've been doing today, and I'm going to do it once more. This disease needed more than anything else was for people to see where the light at the end of the tunnel might be if it wasn't an oncoming train. And when you start talking about the ability to get rapid reversals commercially, that feels like a light at the end of the tunnel, even if people overstate the breadth of its value. But it creates energy, it creates money, it creates momentum, and it creates a lot more excitement to look for the kinds of solutions that Manal is talking about with personalized medicine, or Stephen is talking about with much more focus on AI and machine learning. So to me, the exciting thing is this is starting to look like a sustained effort that could yield fruit in stages as compared to when are we going to get our first big hit, which is, I think, the question people were asking last year. And one of the things that made everyone so disappointed about the Intercept CRL letter. This just feels to me like a more fundamentally sound way to look at the future. Not that OCA might not have a place in it, but this is a lot sounder than hoping AOCA will get approved and then we'll have a drug. It feels like a lot more paths, we're pursuing a lot more paths in parallel in ways that are more likely to have success. That just feels right to me. So, Manal, thanks for joining us today, and thanks for putting up with the
Absolutely. Thank you for having me.
Oh, it's our pleasure. We'll have you back in 2 weeks. And Stephen and Louise, thanks so much for being on today. Thanks to the people from Riverbridge who helped us figure out how to get through today, and now we'll see what a good job they can do with whatever tape we've created, and everybody else, Eric, Mike, Polly, Ryan, all of you who listen. We're looking forward to having Donna back next week. Manal will not be with us, but Donna will be, and Jorn will be here again talking about drug failures, kind of the flip side of all today's excitement. And then we go into AASLD. And the reason I did that was I was saying to myself, for those of you who are listening in the U.S., by the time you listen to this, either the country will be in a complete state of conflagration, or everyone will be looking at each other going, what the heck was that happened? But one way or another, you're going to get your airwaves back on Wednesday. You're not going to get all those TV commercials anymore. And we all go forward. So everybody, stay healthy, stay safe, stay sane. Surf on. We'll see you on the podcast. Have a great week. Bye-bye now.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.